Hello everyone, and thanks very much for inviting me here today. First thing I should say before I show any pictures of anatomy on the screen is your sort of figurehead of your profession is Hippocrates, I suppose. I was grateful for the previous talk because you showed Swiss Tony, because I'm a salesman and he's my sort of spiritual figurehead, and it was all I could do to not stand up and salute whilst he was on. So I'm pretty good with machines. What I'm not so good on is the anatomy, so if you'll forgive me for that, we'll do great. But there's loads of people here that can talk you through all of those bits a bit later. So, ultrasound machines and the back. Before I do that, a whole bunch of anaesthetists here. You're probably all used to doing regional blocks, quite a lot of you. Would that be reasonable? Lots of nods. I'm glad about that. For most regional blocks, you'll be using a straight probe pretty similar to that. Oh, before I go on, we thought with this one, let's combine two things. Like Batman's cool, and so everybody likes toasted sandwiches. So we thought Batman's sandwich toaster, and then we designed the machine around that. So here we go. Let me just get this out. Most of you are probably used to seeing a straight view on the screen of a necky bit. Hold on. I told you I wasn't good on anatomy. I'll call it a necky bit. So we have, subclavian artery and brachial vein. Oh, I'm so sorry. I forgot that light can't go through my body. There we go. Okay, so we're all used to a square kind of image on the screen or a rectangle. The important thing I want you to realise with one of these probes, most of them are 38 millimetres from one side to the other, a set width. From the left bit of the screen to the right bit of the screen, no matter how deep you go, is that same width. Okay, so if you've got a particularly narrow probe for the line placement, like on the old iLux, it will be showing you a 25mm lump of whatever you happen to be shining it at. This one's a bit wider. For the back, we don't use one of those, typically. We use one of these, one of these curved probes. And you might be wondering why. Is it because I'm taking Swiss Tony literally and just selling you another probe for kicks and giggles? No, it's because it does a very different thing. The first thing it will do is see a lot deeper into the patient, because this nice linear probe, no matter how hard you try, will only go, let's try it, 6 centimetres into the patient. It's telling us down the bottom right of the screen that we are seeing 6 centimetres of tissue, and that's it. For the average person in labour where you're trying to look at their back, 6 centimetres isn't going to be your friend. Agreed? Okay. That's the first reason why this isn't any good for you. The other reason why this isn't any good for you is because you're wanting to get spinous processes and a whole bunch of other stuff on the screen at the same time. And because this is typically only going to be 38 millimetres wide, that's not going to work for you. So a curved probe has two benefits. The first one is it goes very, very, very deep. If I put this on my neck, it's going to look, technical term is completely pants. Okay, so the good news is I can go down to 30 centimetres, so it's seeing out of the other side of my neck, which is, nice for it. So 30 centimetres is the kind of depth that you can go to with these probes. The other bit of good news is because it's curved, you get a fan-shaped sector going down the image. The bad news about a fan-shaped sector is the further away you go, the more inaccurate the image is, because if you think about the scan lines coming out of here, they're like the wings in a skate. So the further away, or your fingers spreading out, so the further away they go, the more the machine is having to make stuff up as it goes along as to where things exactly are. But the good news is that as the beams are spreading out, you can see nice wide stuff on there. So with a probe like that, by the time you're 8, 9, 10 centimetres away, you're seeing 10 centimetres of width, which is very good for you. This is why you can get the spinous processes on there. It's why you can scan an entire liver on one of these. And that's what these are for. These are for livers, kidneys, babies, that kind of stuff. That's what these probes do. So if you already have one of these probes on your machine, that's great. If you don't, there may well be a machine in the labour suite that they're using for fetal positioning, and one of these curved probes will do it. What you need to do is find out the settings on the machine to make it look good for nerve work and work around the back. Because if you've got it on the standard obstetric setting, it's probably not going to look so good, because the machine needs to know what are you pointing it at, because this is such a wide-ranging probe that will do a whole bunch of cool stuff. It needs to know what cool stuff you're wanting to do with it. On this machine, it's got a nerve preset, and then if I sort of stick it on the back, I'm going to do a here's one I did earlier rather than drop in the trousers, you will be glad to know. Excuse me. Thank you. So we've got, staying with the bat theme, we've got the Batman side and so on, but what I wanted to just get across to you here is that when we are getting down to the region of interest, we have got a width of 10.7 centimetres, observed top left of the screen, from one side of the screen to the other. So the fact that it is spreading out is the important thing for you, and that's why you need one of these. So you need to find your machine, and you need to find how to put it on a nerve preset. If it's a Sonosite, that's fine. Most other manufacturers have a nerve preset as well, so you'll be able to find it. And shall I hand over to you about there? Okay, that's it for my bit, you'll be glad to know. Thanks.
Okay, good morning. So I'm Dr. Sharma, I'm Anupama Sharma, I'm a consultant anaesthetist at the Mid-Yorkshire Trust, and my only qualification really for giving this talk to you all here is that I practice it. And in my trust, I think I was the one who started doing it in the first place a few years ago, and it all started with a lecture like this in the Royal College, but it was by the expert, it was by Prof. Barbalo, excellent lecture and an excellent workshop at the end of it. And that got me interested in doing this. So like many of us, I'm self-taught, because when we finished training, ultrasound was just about coming in. So it was just a matter of reading, attending some courses, attending with some experts, and then off you go and start practicing. So I'm hoping that I would sort of get you interested. Just out of interest, how many of us here use ultrasound routinely in, say, your practice, whether it's obstetrics or orthopedics while you're doing regional anesthetic? So everybody is already familiar with it and doing it. So I'll just go through why we're doing it and maybe just brush up for any of the few who are not using it routinely. Brilliant. So ultrasound for lumbar puncture was described way back in '71. That's when it first started. And since then, since 2000, Grau and his co-workers have published several case series, and since then the sonoanatomy of the spine has been well described. Following that, the machines are getting better and better, so we are all using, there's increasing availability of the ultrasound machines, so we are using it quite routinely in our practice now. So I'll just speak a little bit about the background, go quickly through the technique, which I can see quite a few of us are already practicing it. When I say demonstration, we have a few spine models which we'll do during the breaks because of the time restrictions. And I have a little bit of time at the end. I might do a quick live demonstration. One of my colleagues has agreed to be a live model here, so we'll see how the times permit. There will be references for further reading and a few websites for you to have a look at, because they're really excellent if you want to teach yourself or refresh everything again. So, is it a useful skill? And many of us who are doing conventional techniques for a long time, we are doing it really successfully, and they work well, not that many complications. So we say, why do we have to use an ultrasound? I find a lot of my trainees, when I say, just bring in the ultrasound machine, and they'll say, this patient is really slim, or it looks quite easy. And the thing with this use of ultrasound is you have to use it in a lot of uncomplicated cases. Just get used to the anatomy, just get used to the easy recognition of the patterns, and that's when you can really use it in the difficult ones. Because the sonoanatomy is not really as crystal clear as I might show in my pictures because these were really slim candidates and where we have done these, photographs. So you have to recognize the patterns because it may not be as clear, but as I'll go on, you'll see that it's still helpful when you have patients with abnormalities or you have really increasingly obese patient population that we have. So the reason why we should use it is because there have been a lot of papers published about the accuracy of this palpation, and I do it every time I'm doing a case. I'll ask my trainee to, or myself, just see where the level we think is L3-4, and then put your probe on, and you're generally estimating a space or two higher. And that combined with the fact that the spine, the conus medullaris, in 37% of the patients might end below the L1-2 level, means there is always that risk of us underestimating, us counting up a bit higher and the spinal cord ending a bit lower. So when you're doing spinal, lumbar punctures at those levels, then there is always a risk of neurological damage, and there are again references at the end which will papers, case reports about that. Secondly, it's the patient population that we are getting more and more. We are seeing, we don't blink an eyelid. 45 BMI, we don't even see them anymore. We just give them the leaflets. Really, we are seeing increasing obesity in especially the obstetric population. People are having a lot of complex surgeries. So we've had patients coming in with post-spinal fusions and surgeries, and it's really helpful in that as well. Apart from obstetrics, when you're doing orthopedics, trauma, you get older patients with degenerative changes, collapsed vertebrae, narrowed spaces. Again, this is an important, a very useful gadget and for those cases as well. There is also mounting evidence now to show that ultrasound is really safe. It increases, locates the midline and basically guides your procedure much better, more accurately. Benefits, well, I think it's all benefits. They are all easily available now. Most of our departments will have it, and if we don't have the curvilinear probe, when I started, we didn't have the curvilinear probe, and I just used to use the obstetric, the fetal ultrasound to just use the curvilinear probe, and that was fine. It's really easy to use. Now it's all portable, and you can just take it. You can get real-time images, so when you're having difficulty, you can quickly drag it in. It doesn't take very long once you've started doing it, especially if you're doing it day in, day out in most of your cases. It is beneficial 100% in patients with abnormal variant anatomy. I've had recently quite obese patients, patients who have had spinal fusions, and you can still find that one space where you can perform a successful spinal injection. It is foremost, I think it's a useful teaching tool. All of us who are consultants here, and we know that the first epidural that a trainee does is with us in the labor ward. So all you can say is, are you sure you're feeling those resistances? Are you sure you're, and you can actually hear and see what they're doing. But here it just reassures you. You've scanned the back, you know exactly where the depths are, you know where the midlines are, and you can guide your trainees. So whether the trainees are happier or not, I'm really much happier when I'm doing the ultrasound technique. Also, when I have difficult patients where it's just consultant only, and if I pre-scan the patient, I have a slightly senior experienced trainee with me, then I can allow them to do the procedure knowing, of course with supervision, because you've scanned the back, you're doing it in a safe manner, and so really safe, really good, and really easy to learn and use. So in 2008, because of all these trials and there were randomized controlled trials, and there was a lot of evidence to show that use of ultrasound is really good in the terms of success. So number of attempts, number of needle insertions is all reduced, whether it's by experienced users or by the trainees. Also, it improves the efficacy of epidural analgesia. So there are studies supporting that as well. So not only is the technique become easier, it is also the analgesia is much better using the ultrasound. So at that stage, it was incorporated into the NICE pathway on intrapartum care. At the end of that year, they did a survey amongst anesthetists to see if these NICE guidelines were followed upon, whether people had got any training on it, and 90% of the anesthetists who had responded to that question had no training and were not using it. So obviously a lot has changed. Most of us I can see here are using this technique, and that's quite encouraging. That's very good. So is it easy to learn for those who don't do it and who think, oh, is it easy enough to learn? Well, it is. The studies in this paper where there were 2 emergency physicians who had never done this before. As a training process, they did 10 scans each, and then they were let loose on the patients, well, not to do any procedure, but to identify not 15 structures, sorry, 5 structures, which is the spinous processes, ligamentum flavum, dura, epidural space, subarachnoid space. Not very fat patients, average BMI was 31, and it took less than 5 minutes for both of them to identify the space, all these structures within 5 minutes in 100% of the patients. So it's a quick learning curve. So, as I'll go forward, there's only a few images to get familiar with, and then off you go. For any of the references, there was a meta-analysis and a systematic review in BMJ in 2013, which again shows that it reduces the risk of failed and traumatic lumbar puncture, and they have advocated that it should be used for these procedures. So how do we use this? There's 2 ways of doing it. Ultrasound guided, where you observe the needle real time while scanning. But this is very tricky because the footprint of the probe, as you can see, it's quite big. The angles at which we have to approach the space are very narrow. So it's really difficult to manage all that in a very septic, sterile manner with all the gel and everything that is involved. So I'll only be focusing on the ultrasound assisted method, which what we do here is a pre-puncture ultrasound. So you scan the patient's back before your procedure, you mark your space out, so the area of interest, you determine the location, you determine the depth, and then just use it as a guide for your conventional technique, which is what we do normally. So I just split it into really 4 simple steps, and so the way I'll do this is just 2 images that we need to know. One is a transverse view and one is a longitudinal view. In the transverse view, I say 2 images. In the transverse, there's like a 1A and 1B, and then the longitudinal is just the 1 view. So only 2 images that we need to master, and then just put them into these 4 steps, and that's it. You mark your spot, and the catheterization of the lumbar puncture is then done in just the normal conventional way. So he's already, Gary has spoken about this. We use a low frequency probe, and because you need a lot of penetration, and resolution is not all that important because you're just seeing big bones and ligaments, so that's fine. It's not like you're aiming for little nerves. So curvilinear low frequency probe is what we use for this method. So to know it's really important you're aware of you know your vertebral anatomy well, because that's what translates into the sonoanatomy. So what you're looking at is the ultrasound waves bouncing off the bones, giving you the hyperechoic images. So when it's bouncing off the bones, all you will see is the hyperechoic image, but you wouldn't see anything sort of going underneath that. It will just be a darkness. The ligaments will come across as hyperechoic, but they won't be as bright as the bone, but you'll still be able to go through it, so which means that through the ligamentum flavum, the ultrasound beam can pass through the spinal canal, and it will bounce off the vertebral body, so you should be able to see that. So the main structures that we need to see are the transverse processes. I don't have a pointer, I don't know how. Anyway, but basically what in the transverse view you see is these 2 on either side, so 2 lines on either side, so transverse processes. So in the further images, TP is the transverse processes, and then you see the articular processes, and what joins them in the middle, from lamina to lamina is the ligamentum flavum with dura closely attached to it. So what you will see the structures, you'll see the transverse processes lying on either side, then you'll see the pointy things, which is articular processes, and you'll see the ligamentum flavum and dura, which is called the posterior complex. The ultrasound beam then passes through the spinal canal, which usually just shows us darkness, and then bounces off the vertebral body with the posterior longitudinal ligament, and that will show up as a bright line as well. So I'll talk about the transverse view, and I will talk about a longitudinal view, and these are the structures that we'll be seeing in every image. So just like I said, the two images that we need to know is the transverse view, and this is called a flying back pattern. There's two images here. The one on the left is the real image, and the right is just like an artistically enhanced version, just to say why we call it a back swing appearance. So what you're seeing, if you remember that vertebra there, is, like I said, two transverse processes. So here your probe is lying transverse to the longitudinal axis of your spinal canal. So what we are seeing here is then the two transverse processes on either side, then the articular processes, and you should see like a little line joining the two pointy things. So those are the wings, those are the ears and the head. The beam then passes through the posterior complex, that is the area of our interest, which is epidural, the ligamentum flavum and the dura. Sometimes you can see them as two fine lines here, or sometimes it just looks as a big bright white line. It depends on how your acoustics are. So the beam is then passing through the spinal canal, and that's the spinal canal, and then bounces off the vertebral body there, and that's what you see. So if you can get this image, that's the best one to have. If you can get this image, you can mark your interspace and the midline, and I'll tell you how. But it's not always easy to get, and not easy to get in bigger, obese or difficult patients. But that's the first view you need to remember, is the transverse view, and this is the interspinous view. So you're seeing from the gap between the bones. So when you're doing ultrasound of the spine, you just have two acoustic windows. One is the interspinous window, and if you go laterally, it's the interlaminar window, because that's where your needle will pass. That's the approach. And so the interspinous acoustic window is the flying back pattern view. That's number one. If you move your probe slightly, Keflard or Cordart, such that your transverse probe is now lying exactly over the spinous process, then it's lying exactly over a bone, so you're not going to see any soft tissues underneath that. So you see the hyperechoic structure here, which is the spinous process, all this darkness underneath, and this just needs basic skills that even in the most biggest, fattest of the patients, you can still see this, and this is the view that's required for charting out the midline. So you're seeing the spinous process, and these are the lamina on either side, if you remember what the vertebra looked like. And these are all the muscles on the side, erector spinal muscles. So the lamina. So main is the spinous process. This must be a really slim patient, just right under the skin. I've had patients where this starts way below 5, 6, 7 centimeters, where you're morbidly obese patients. So that is why you have to do these in a lot of normal patients. So you sort of start recognizing the patterns. Once you know these patterns, only two patterns to recognize. So if you can recognize this, that's great. You know your midlines. You can't palpate anything. You can still get your midlines by doing this. So that's the transverse views over. And then moving on, we move to the longitudinal view, and that's called a sawtooth pattern. So two patterns, flying back, we've done it, and the sawtooth pattern. So this is the other window from the side, the interlaminar. So that's the gap between the laminae, and that's where you want to look into the spinal canal. So you place your probe paramedian, not on the bone. If you put it on the lamina, you're not going to see anything. So you want to, if you look straight back, you'll only see the bone. It won't allow you to see anything. So you tilt it ever so slightly to look into the spinal canal, and that's where you're looking in. So you place your probe paramedian and looking sort of into the spinal canal. And what then you should see is the sacrum, which is a flat plate of bone. It should bounce off the ultrasound beams, and you'll see this flat plate, and that's the sacrum. When you start doing this scan, you must identify the sacrum. That's the only way you can accurately count your levels, so count your laminae. So this is the sacrum, flat plate. The first break, that's the lumbosacral junction, and then you start seeing these humps coming into view, these bumps. And as you keep moving up, the probe the beams keep hitting the laminae, and you'll keep getting this sawtooth or a thicket or like a fence pattern. Yeah? So these keep coming into view, and the breaks then are the interlaminar spaces. That's where your ligamentum flavum is. So that's joining it runs from lamina to lamina, bone to bone. So the line, this break, is your posterior complex, which was the ligamentum flavum dura. If you angulate it correctly enough such that your beam is passing through the canal and hitting the other end of the spinal canal, so it's going right through and hitting the vertebral body, then what you should see is, that's all the subcutaneous tissue. The ultrasound beam is passing through the ligamentum flavum. You should see a darkness of the spinal canal and other bright line coming into view. So it's just a close-up of one space here. So you can see lamina, that's the posterior complex. Then the ultrasound beam is passing through your spinal canal, it's bouncing off the vertebral body. So when I started doing it initially, because I was self-taught, you always get confused as you just think maybe that is the ligamentum flavum. It's not. It's in disconnect from the bone, so it cannot be ligamentum flavum. It has to be in connection with the lamina. So you must angulate enough to get this anterior complex in view, and that's your trajectory. It also gives you a little angle at which, because if the ultrasound beam is going in at that angle, then your needle should be able to go in at that angle. There's enough space there for that to happen. So that's the picture that you want to see. So that's your longitudinal view. So only 2 views to master. So then once you know the 2 views that you have to see, then you put those 4 steps, which is, so that's just a close-up of that same thing, showing you, the sawtooth pattern. So you'll keep seeing these laminae coming, and if time permits, we'll just do, like I said, one live demonstration. Otherwise, we'll do it on, you can use our models to practice it. So that's what the probe is kept longitudinally. So first step is to identify the lumbar level. When I say lumbar level, it's the interface, whichever you're interested in, L2, 3, L3, 4. It's all a matter of counting, right? So what you're doing is you're identifying the sacrum. So you put your probe and you're not looking there, you're looking down and inside. So you identify your sacrum, which will be a long plate, and then start identifying the little humps. They are the laminae, and then little lines joining that. But you must angulate enough to get the anterior complex, and that's the view. Once you have the area of interest, say if you're interested in L45 space, bring it right to the middle of the screen. So bring it there, stabilize your probe there, freeze you can just stabilize your probe there, and then midpoint of the probe corresponds to the interspace that you're interested in. So middle of the screen is the middle of the probe, and that's the interspace marking. So you just take a pen and the back and just mark a line on that side, middle of the probe. And that's your level sorted. So you found your lumbar level. Move on then, and you want to find your midline. And this is the easy one. This image is the easiest one to get. You can always see the spine. So same principle applies. You identify your spinous process, all the darkness within, and then bring it right into the midline. So the middle of the probe again is now corresponding to the midline. So you've marked a line on top there. So draw a line on top. So there you go, the first two steps done. Once you've marked it, just crisscross and X marks the spot, and then you just follow your conventional technique. So obviously before you start doing all this, the patient should be in the right position, in the position in which you're going to actually perform the procedure, because all the line markings, you have to be fairly meticulous with your line markings, and if you think it may have moved, then you have to keep that in your mind, that maybe it's just a little bit. But just be quite meticulous, get the patient position right, properly flexed, and get the markings right. So, in this picture, if you can get that flying back pattern, that's the best one to get, because in one go, you can mark the midline and you can mark the interspace. Because you're sitting right on top of a space, you're being able to see through and through into the space, which means if you stabilize your probe there, this side here, the middle of this is your interspace, and the middle there is your midline, and that's it, you're done. But that view is not easy at all to get, and where you really need it desperately in bigger patients, it's really, really hard, and you waste time, and everybody's fretting. As soon as you get the ultrasound out, people start fretting. They think it's going to take time. It doesn't. It actually saves a lot of time. But people get uneasy, and then if your trainee is doing it or something, they get uneasy. So it's just, what I say is just do the longitudinal view to mark your, the level, do the midline view, mark your midline, and just carry on. It's quick and easy to do. And last, the fourth step, you want to know the depth. Especially if you are supervising, you want to know the depth to see what they're up to. So in this, it correlates simulates quite well. This is the paramedian view. So you might think we are doing all the procedures midline, so would it matter? But again, there are studies to show that they correlate pretty well within the 0.23 millimeters of each other. So it's not too much of a worry. And anyways, because you're following a conventional technique, it's giving you a guide. It's a guide. You're not sort of doing away with what you usually do, all the precautions you take. So in this picture, you can see the ligamentum flavum and dura. You can see them as two distinct lines. You don't always see that. You can just see a bright line. So remember, the line joining the laminae is the posterior complex, is what you're interested in, and just keep focusing till you get this sort of image where you start seeing this line. Again, in difficult ones, it's not really obvious, but even then, if you know the breaks, at least you know where the interspace is. Even if you don't know the trajectory, you still know the level and interspace. So that's done really. That was sort of a quick run through that. Just a quick demo, if I can, if this works. So that's the scanning starting from the sacrum, and as you move up, you can see the spaces are coming into view. Just keep moving carefully, and the spaces keep coming into view. And obviously, this is a nice slim patient, as you can see. It's like 4 centimeters, 3 centimeters, nice one. That's why I've taken the video on that one. So, because I'm running out of time, we'll stop it there. And then, this is the best view to get. If you can get this, best view to get. And it's called a smiley face view. So, if you can keep angulating, just keep running that way. So, as you keep angulating, this smiley thing, it's like two lips. So, the bat's wing appearance. This is your ligamentum flavum. That's the one you're measuring your depth from. And if you move it up, you can see the spinous process has started coming into view. So keep moving up, the spinous process and the laminae are coming into view. So just these two images, that's all you need to know to be able to do this successfully, really. And that's it. Am I done, Sarah? So I won't say that. Really good. That's all I'll say. And extremely useful in difficult ones, but you must keep using it in the easy ones. Just a quick clinical things is, when you're pushing in the bigger patients, you're exerting quite a lot of pressure with your probe. So when you freeze the image, before you freeze the image, take the pressure off a little bit so that you're measuring more accurately. Otherwise, you'll underestimate the depth. Make sure you position your patient well, and where you need it most, degenerative changes, surgical changes, it's more difficult. So keep practicing, keep doing it, and that's it. Quick references. That's it. Thank you.
Time to take just one question, because I will be available during the coffee breaks and lunch breaks to be giving you real-on demonstrations on mannequins at the front and the back. So just one question, please. Anybody got a question for Anu?
How much does it cost?
I don't know the costing, sorry. Cost for what, sorry? The probes.
Kit. How much?
Gary.
That's Gary.
How much it cost?
Can't have it, Simon.
That one will unfreight 32 grand. But you can get something suitable for high teens.